that is a little bit more thought out than what we've seen the rest of this week. So appreciate the opportunity to be here with you. As you mentioned, I am Tara Mays with the Kansas Hospital Association, and I appear before you today on behalf of our association's 122 member hospitals to support Senate Bill 175. As you all are probably well aware, hospitals in rural parts of our state face many very unique challenges, whether that's stemming from our evolving demographics, from reimbursement reductions, from heavy regulatory burdens that can contribute to added costs. We know that many of our rural hospitals are facing tough challenges that require the very unique kind of perseverance and innovation that really and truly can only come from our state's very highly talented rural areas and communities throughout Kansas. We know that those financial losses, for many reasons that I've just mentioned before, can place a heavy burden on our state's struggling hospitals. And just like a lot of rural Kansans, our hospitals take very, very seriously their responsibility to provide core community infrastructure services to the Kansans and the patients that they serve. It is in that spirit that our Kansas hospitals remain committed to keeping their doors open and serving patients, no matter how difficult of the trying times or challenges, financial or otherwise, that they may face. And I think through the course of this pandemic, we've seen that perhaps now more than ever. Our hospitals have continued to seek new ways to ensure that they can provide the quality of care that our rural Kansans have come to depend on. One way that we at the Kansas Hospital Association have been assisting our members is by working since 2012 towards the development of an alternative rural health model. In the past, you might have heard KHA talk about this as a primary health center model. This concept is now codified in federal statute, but it's very similar in structure, but now called the Rural Emergency Hospital Model, which is now appears before you in Senate Bill 175. The model offers a sustainable option for our rural communities to provide an emphasis on the care that is most desired and most accessed in the communities across our state. It allows them to get rid of the parts of their health service model that are less utilized. We know that healthcare is not the same as it was even 10 to 15 years ago. Procedures that used to require quite lengthy stays and overnight inpatient treatment within the hospital aren't what they used to be. Those procedures are largely far more effective today, more efficient, and they require far less inpatient care. But while healthcare has changed drastically, some quality of care things just haven't changed at all. The need for quality of care to both keep patients healthy, but also to be available to their communities 24 hours a day, 7 days a week remains critically important today. This rural emergency hospital model that's before you today allows our health facilities to focus on the services that are sought by Kansans in the areas of preventative and primary care, chronic disease management, and those emergency medical services most needed. This rural emergency hospital model allows for local hospitals to serve as an access point to coordinate the overall care if higher levels of care are warranted on a regional basis. It's important for the committee to understand that this bill and the model of rural emergency hospitals doesn't require any hospitals to have to change what they're doing right now. It allows hospitals to opt in if this is a tool that's right for their community. It also doesn't prevent a hospital from implementing this new model and then returning to their former designation as either a PPS or a critical access hospital. This model is not prescriptive in that additional services that might be right for a community can still be included and incorporated within that model. For example, important services such as prenatal and postnatal care are of the utmost importance and can be accommodated through a rural emergency hospital, with the delivery itself being something done at a regional level, which is an exception to in emergency situations, obviously, that could happen at a rural emergency hospital. In many cases, that care is already not occurring, and these very important services continue to be vital to sustaining growing families and keeping them in our rural communities. After many years working with the Kansas federal delegation, we are pleased that in December 2020 version of the CARES Act that passed at the federal level included the creation of our very similar plan to what KHA has been exploring since 2012 and with our membership for the last several years. The federal legislation requires state legislation designations that follow and are in alignment to implement this new payment delivery model, where it would make sense for any given hospital or their community. We know that there are likely still questions that remain to be answered through CMS guidance and the rules and regulations process that will be propagated at the federal level in the months to come. Important things like if there will be any grandfathered facilities that have already had to shut their doors over the last few years that could be eligible under this program, those questions remain yet to be answered by the federal guidance that will come. But now is the time to build on the work that KHA has done to date and that Kansas hospitals, to ensure that our Kansas hospitals don't get left behind and allow those that are interested in this option to be available to take advantage of this as one tool in their tool belt. The rule model is one that KHA has done a lot of work on, as I mentioned, over the years. And to talk to you more a little bit about the history and kind of what we've done, I'm joined by my colleague, Jennifer Finley, with the KHA, Vice President of Education and Special Projects. And at the appropriate time, I would turn it over to her, but I will also be happy to answer any questions that you have, Mr. Chairman, at the appropriate time.
Tara, thank you. And committee, since we don't have that many testifying today, I think we'll go ahead and open up for questions for the conferee at this time. Committee members, do we have any questions for the conferee? Senator Stephan.
Chairman, it's very clear to me that reimbursement is ultimately what causes change. At every step, entities are always adapting because upstream reimbursement has been changed and forces the people to change. I'd like for you to provide me with some real hard data on how the reimbursements are changing for these emergency hospitals versus the typical hospital. I'd like for you to educate me on exactly what the reimbursement changes are. And you don't have to do that today.
Yeah, I certainly appreciate that question. I think that kind of falls a little bit into one of those categories that sort of it remains to be seen, but we'd be happy to provide you some anecdotal data of what we've seen through the process and the history when we've seen hospitals that converted to critical access hospitals. Perhaps that would be helpful as a historical perspective to be.
I don't mean to cut you off. I don't think so. I know this new designation is going to have distinct reimbursement changes attached to it. I want to know exactly what those reimbursement changes are.
I'd be happy to get you some additional follow-up information on the reimbursement changes as that information is available to us. Appreciate that.
Senator Petty.
Thank you, Mr. Chairman. And Tara, thank you so much, because I know that this is something that the Kansas Hospital Association has been working on for years now to communities access and continual access that the communities can afford and provides the needs that they want to see. I agree. I think it's
Appreciate those comments, Senator. As you all are well aware, Kansas was kind of a leader in critical access hospitals when that was passed several years ago. And we think that this could provide a very good and unique advantage for those hospitals that might be looking at doing that community input work to really explore a little bit further if this is a right option and a right model for them. So appreciate that.
Senator O'Shea.
Thank you, Mr. Chair. If the hospitals do move to this model and then they find that it maybe isn't a good fit and want to move back or to different licensure types, is that feasible?
Yes, absolutely. I appreciate the question. So the way that the model is structured, there's nothing that prohibits a critical access hospital today that might look to become a rural emergency hospital in the future. There's nothing preventing them from going back to a critical access hospital later if for some reason, or a PPS system, if that's something that works better for them.
Senator Gossage.
Thank you, Mr. Chair. Tara, thank you for being here. We've had several different conversations about this, but especially for those that are listening in. Could you clarify the requirements to be a critical access hospital and how that contrasts, because we have in the bill itself to be a rural emergency hospital and the requirements to be one. How is that different than the critical?
So yes, so currently right now, the critical access hospitals, and Jennifer might be able to provide a little bit more background and history on this particular piece, but currently critical access hospitals are required to have a minimum level of overnight beds. And the difference between the critical access model and the rural emergency hospital model is that that piece would no longer be in place once they move to the rural emergency hospital designation model. I hope that answers your question.
Then the next question I have is I would refer you to Section 8 of the bill. Insurance background. This reads a bit like a mandate, saying all of these insurance plans, HMOs, et cetera, must accept these hospitals in their coverage. And typically, that is something that is decided on a contractual basis between the hospital. I can't imagine why it wouldn't be. Accustomed to seeing mandating them to be.
I appreciate that question, Senator. And we've had some dialogue around that particular new section. Really, from our perspective, the PPS model, or the critical access hospital that exists today that would be looking to convert to a rural emergency hospital, this language just says that whatever is insured today contractually would need to be contractualized and negotiated with those same coverage points in the future with a rural access hospital. So it really is not designed to be prescriptive in nature, only to say that when we establish critical access hospitals, this negotiation piece was within there, whether you're an in-network or out-of-network provider, and we would just like and ask that those hospitals be treated the same, rural emergency hospitals, as the critical access hospital or the PPS system is today.
And is this language, the same language in the access?
It,
Where can we find that?
yes.
Several references to KSA 39709.
Yes, so very similar language, appreciate that question. Very similar language existed when the critical access hospitals came about, and I'd be happy to provide you kind of a site notation a little bit later on where that language was. I'd be happy to.
Senator Baumgartner.
Thank you, Madam Chair, I apologize. Thank you, Mr. Chair. I apologize. I don't know.
Can someone get Senator Baumgartner some more coffee, please?
Please, I've been up since 3:30, so, okay, my brain was somewhere else. I just wanted to share one of the concerns that I've had several conversations about. One of my concerns happens to be what we learned in the interim and what we've learned with hearings about rural care. And that is, it was the Hospital Association that shared with us the data that the number one driving force for people going to their local hospital is having the presence of OBGYN services, delivery rooms in their actual hospital. And part of my concern when we are looking at perinatal care, so prior to delivery and that year after delivery and the emergencies that can occur, my concern is that there would be an absence of those delivery rooms as the hospitals make that change. And individual communities and individual hospitals will be making a decision. And my concern is what we often see is this, where the one makes the decision that we're not going to have that, assuming that the others in neighboring communities might have that. And when we are looking at the increase that we have of prenatal deaths, postpartum deaths as well as infant deaths, I think it is crucial that if we are really interested in families growing and staying in rural populations, then we must have labor and delivery suites, and we must have that perinatal service available. And I say that knowing full well where I live. If you live in Miami County, Lynn County, Anderson County, if you just go down the swath, you're going to have to drive 1 to 2 hours to get to a labor and delivery suite facility. And that is on the eastern version or area of the state. We're not even talking about our western portion of the state. So I understand the need for these changes, but it is a concern to me that we will not have that available, and it's counter to the data that's been shared with us as having labor and delivery being important for rural communities. Thank you, Mr. Chair.
If I may, Mr. Chair, I think Senator Baumgartner brings up a really, really good point and something that's been it's going to be very important through the community input process. But one of the things that rural emergency hospitals allow that I think is really important as it relates to that prenatal and postnatal care that you mentioned is the ability for mom and baby to some extent to be able to get that at home. Because while we know, as you mentioned, kind of those labor and delivery services are certainly a crucial component. What the goal is to be able to get as much service as possible around that having to have an overnight stay piece at home and as close to home as possible. So we're hopeful that rural emergency hospitals can continue to provide some solutions for mom and baby, both leading up to delivery and post-delivery. So I certainly appreciate that. And I think, as you mentioned, certainly those types of conversations will have to be a key component when we discuss with community levels if Senate Bill 175 goes through, kind of how to regionalize that in a way that's beneficial for all of the patients and all moms and babies in the community. So appreciate that comment.
Okay, not a question, but more of a comment. And I noticed that we did receive written testimony from both of our U.S. senators. And just for those in the committee that aren't familiar with the Emergency Medical Treatment and Labor Act, it was an act that was passed in 1986 by our U.S. government that mandated that all hospitals provide emergency care, stabilize them, regardless of ability to pay. And that is probably the single largest factor on why rural hospitals are struggling today, because that's an unfunded mandate to them. So they do not have that opportunity. I do appreciate the federal government trying to make a attempt to kind of fund this mandate that they put on us in '86 on the hospitals. I do wish that they would do a little bit more, because emergency care is the single largest charitable medical expense a hospital has. So with that, we will go on to Jennifer Finley. Jennifer, welcome to the committee.
Good morning. Thanks for having me. Just a couple of things to add to what Tara talked about. As she mentioned, this is something that we started working on with our members in 2012. It is an approach that is Kansas-based that we believe really will meet the needs of many of our small rural communities. Again, it's not something that every community will select, and we would not want every community to convert to a rural emergency hospital because we need a good regionalized approach, and it will be up to each region to look at the services provided in that area and make sure they have a good complement of services. Our preliminary research around this concept shows that for many of our small rural communities, 75% of the patients that they currently see in their emergency rooms would continue to be served under this new model. We also think it's important to note that this new reimbursement approach will provide some stability to the challenging financial position that many of our small rural communities find themselves in. A key component to making sure that our communities are ready to consider new options is to make sure that we're communicating and educating everyone about the challenges facing rural healthcare and then again, those opportunities that exist. So we have partnered with the United Methodist Health Ministry Fund and the Kansas Health Foundation and have been holding a series of virtual conversations across the state regionally to start to have these conversations. We're hoping once the pandemic lifts and we can gather together in groups again, that we'll be able to go into individual communities and start those conversations too. Change can be scary, and so we want to make sure that folks have lots of information and that communities are really prepared to make those decisions that work best for them. In the beginning, we only anticipate we'll have a few communities that decide to try this approach. That's the way these kinds of programs work, the way that it worked when we moved to the critical access hospital program. But for those communities, this is a really important lifeline, and we want to make sure that Kansas has it available now that the federal government has enabled this new provider type. I'd be happy to answer any additional questions that you might have.
Thank you. Committee members, do we have any questions for Jennifer? Okay, seeing none. Thank you, Jennifer. Next up, we have Larry Vanderwege, Administrator for the Lindsborg Hospital. Larry, welcome to the committee.
Thank you, Mr. Chairman. As he said, I'm Larry Vanderwege, Administrator of Lindsborg Community Hospital. I entered healthcare in 1996 as a physical therapist and worked into administration in the mid-2000s. I became the Administrator CEO of LCH in January of 2008. I'm honored and appreciate the opportunity to provide written testimony and comments in support of Senate Bill 175, which creates the rural emergency hospital for our state. I think if you ask my managers and medical staff members what is a common phrase that I use when working on problems, they would say I often ask, what are our options? Having options is key to finding solutions. Dwindling options is what led the Kansas Hospital Association to form a working group to work on rural health visioning. Unfortunately, the changing landscape of local demographics, along with the reforming delivery of healthcare, create challenges that the usual advocacy and tactical efforts cannot overcome. Our work started with a blank canvas, our work group tried to erase from our minds, to the degree possible, healthcare delivery as we know it. We started with a blank canvas and said if we were to create a healthcare organization for rural Kansas, what would it look like and how would it be funded? Quite often, individuals and organizations just want to sit and wait for government or some other entity to provide a solution. I am proud of the KHA and our working group because we decided to help develop a solution, not just complain about the problem. The need for a new model is not unique to Kansas. Throughout its development, and especially after the white paper was completed, hospitals and state organizations throughout the country expressed interest and intrigue in our work. So current options for CEOs like me include staying as a prospective payment hospital or critical access hospital, even when inpatient volumes don't justify the expense of inpatient beds, or becoming a freestanding emergency department or urgent care clinic, or becoming a clinic or federally qualified health center. Each has its own benefits, but also limitations, especially for a community trying to provide the needed health services to try and maintain the health and vitality of its rural community. Becoming part of a system is also an option for many, such as the decision LCH made in 2012 to become part of Salina Regional Health Center. At the same time, not every larger facility is willing to form an affiliation with every smaller facility, and even if that is the case, the smaller facility needs to be financially viable. So I believe strongly that the rural emergency hospital is a new option needed, not for all, and possibly only a few, but needed nonetheless. It would enable a struggling hospital to shed the expense of maintaining unneeded acute care beds while maintaining what is most needed. This includes primary care providers, emergency and possibly urgent care, lab, radiology, rehab, and other necessary ancillary services. It would require transfer agreements with larger nearby facilities and a robust EMS for life-saving transport. Post-acute beds would also be allowed for the often necessary rehab for a patient returning from the tertiary hospital. I realize the financial reimbursement of the rural emergency hospital is still in development, but our anticipation is that it will provide a budgeted block type payment that provides stable monthly cash flow and take into account quality and volume changes. It also must achieve the triple aim of reduce cost to the overall healthcare system, provide high quality care while maintaining or even expanding access to the citizens of Kansas. Anything less isn't acceptable. Rural hospital boards, administrations, and medical staffs need options to meet today's challenges. Senate Bill 175 gives them a much needed option for some. Thank you for your consideration and hopefully support of the Rural Emergency Hospital. Thank you, Mr. Chairman.
Thank you for your testimony. Committee members, do we have any questions for Larry? Seeing none. Larry, thank you again. Next up is Dennis Shelby. He is the CEO for the Wilson Medical Center. Dennis, welcome to the committee.
Thank you, Mr. Chairman. I find it a privilege to be able to speak with all of you today. And I am Dennis Shelby. I am CEO of Wilson Medical Center in Neodesha. I've been in the community, I've been in Southeast Kansas, serving in Neodesha for over 10 years. I also was fortunate to be on the primary health center committee that met over a number of years and very supportive of the rural emergency hospital. I have submitted a letter to you, and hopefully if you have that before you, feel free to ask me any questions when I'm done. I'm not going to read that letter to you. What I want to do instead is share a real life story of something that happened last week in my community that involved my wife. The rural emergency hospital would have been the perfect model of care to address the situation where my wife fell on ice, had a concussion. So as the situation went, we arrived at the emergency room. We were greeted by RN staff, and she was taken immediately to CT to have a scan of her brain to see if there was a bleed. Fortunately, there was not. A complete evaluation by a qualified medical provider was performed, and she was found to have a moderate concussion requiring 2-hour neurological assessments by a registered nurse. She was placed in an observation status to be evaluated for the next 16 hours, then released to me. Had there been a bleed or her neurological status worsened, she would have been transferred by local EMS to a higher level facility. Everything my wife received could have been provided in a rural emergency hospital. There are communities in Kansas and across the nation that need this option to convert to this level of service, allowing citizens to receive appropriate health care near their homes. I have seen 3 hospitals near in Southeast Kansas. I am asking the committee to recommend and support the necessary changes required so Kansans can have quality, accessible, appropriate health care instead of seeing their hospital closed. I am available, Mr. Chairman, for any questions that the committee may have. Thank you for allowing me to be here today.
Dennis, thank you for your testimony, and glad to hear that your wife is doing better. She's still on the mend. Committee members, do we have any questions for Dennis? Seeing none. Dennis, again, thank you for your testimony. Committee members, at this time, I would draw your attention to the proponent written only testimony. We have several there. They should all be available. Is there anybody else wanting to testify as a proponent on this bill? Okay, seeing none, we do not have any neutral testimony. Anybody wishing to testify as a neutral? Seeing none, we also do not have any opponent testimony listed. Is there anybody wanting to testify as an opponent? Okay, not seeing any, we will now close the hearing on Senate Bill 175. Committee, it is my intention to work this bill either Tuesday or Wednesday. So if you do have any questions that you need to get answered, or if you have any amendments that you want to offer, please get with the reviser and get those drafted as quickly as possible so we can get this worked. Just a reminder, next week is the last week we have before turnaround. For those of you that are new to this process, that just means that because we are a non-exempt committee, if it is not a blessed bill and it is a Senate bill, we will not be working that bill after turnaround. So the only bills that we will be working after turnaround will be a House bill or a bill that is blessed. And with that, just to give you a heads up for next week, we are going to have hearings on Tuesday for Senate Bill 170 and 138. On Wednesday, it'll be Senate Bill 238. Thursday is Senate Bill 200. And I would go ahead and plan on having a meeting Friday because that will be our last day. We're going to use that as a carryover day and a day to work any bills that we need to get worked. So with that, if there's nothing else for the committee, we are adjourned. Thank you, everybody.